Thanks everyone for giving me the opportunity to talk about our applications of predictive analytics to improve cancer care delivery, particularly using it to increase and improve serious illness communication among patients with cancer. My name is Ravi Parikh, and I'm an oncologist and a researcher at the University of Pennsylvania and at the Philadelphia VA Medical Center. These are my disclosure. I think it's safe to say that we're living in the age of big data. With the advent of electronic health records, I have access to everything from a patient's laboratories, to a patient's imaging, to a patient's hospitalizations and genetics, and a variety of other prognostically relevant data at the click of a finger in real time. I think with the advent of predictive analytics by companies like Netflix and Amazon that we use in one way or another every single day, there's been a lot of excitement about applying analytics to oncology care that help improve oncology practice. But I'd argue that there's a problem of synthesis and implementation. How do we synthesize this data to generate a prediction that's better than what we would do ourselves as clinicians? And how do we deliver that prediction so that it actually helps improve someone's care and doesn't just sit in someone's email inbox? I'd argue that one of the most important, if not the most important application of predictive analytics is when it comes to prognosing someone's life expectancy or treatment trajectory for someone with cancer. When someone asks me in clinic, "Doc, how long do I have?" Usually I look at a few different sources of data. Sometimes I look at data from a randomized trial. Sometimes I'll look at data from a population level estimate for patients like them. Sometimes for select diseases, I'll actually plug a patient's numbers into a model to generate a life expectancy. But I'd argue that for the most part, I rely on my own intuition. And the problem with intuition is that oftentimes we as oncologists get life expectancy wrong. What you can see on the right-hand side is a graph from a prospective study by Nicholas Christakis and Elizabeth Lamont, showing that when clinicians were prospectively surveyed for patients with advanced cancer, they usually overestimated life expectancy, oftentimes by a 3- to 4-fold factor. Overly optimistic prognoses are not benign. They've been shown to increase unwarranted utilization or therapy, particularly near the end of life, and delay conversations, important conversations about goals of care and transitions to hospice. At the University of Pennsylvania, we've recognized that early conversations about goals and preferences improve goal concordant care and may decrease unwarranted utilization. Since 2018, we've deployed the Serious Illness Conversation Guide, a structured checklist of sorts to elicit patient preferences, treatment preferences, and trade-offs, particularly at the end of life. Despite training clinicians since 2018 on how to use the guide, serious illness conversation documentation had been decreasing at Penn for much of 2018. In response to concerns and questions around how to identify patients who are appropriate for a conversation, we developed a machine learning classifier to predict palliative care need using structured data from our own electronic health record. We used structured data from a variety of domains, including demographics, comorbidities, EKG values, laboratories, and some select cancer-specific data to develop a machine learning algorithm that, after accounting for missing data and highly correlated features, used 559 structured variables to predict 6-month mortality, which was our surrogate for palliative care need. We used a pretty unique approach, I would say, to implement this algorithm into practice, and I highlight it here because I think it's generalizable for many different predictive algorithms, even outside of this specific clinical area. We first conducted rigorous qualitative interviews to actually assess the problem and assess some of the barriers towards identifying patients who may be appropriate for a conversation. We then actually developed and validated our algorithm using the machine learning technique and comparing it against several other standard techniques to show that it was the best. We then put predictions in front of clinicians to actually see how they reacted to predictions and whether they thought that was accurate. We then prospectively validated our algorithm in a real-time setting at the point of care. And then after a short feasibility pilot at one of our community oncology practices, we deployed the algorithm as part of a multi-pronged intervention in our tertiary academic practices and a select general oncology practices. And I'm going to get into the details now. First, the algorithm. Our algorithm, trained to predict 6-month mortality, had extremely good ability to discriminate between patients at low risk of predicted mortality, indicated by the orange line here, versus high risk of predicted 6-month mortality, indicated by the blue line here. And in fact, among the 2 or 3% or so of high-risk patients, nearly 50% died at 6 months. I think everyone would indicate that this is a particularly high-risk group. When we actually put predictions in front of clinicians, about 60% of assessed patients were deemed appropriate for a conversation in the upcoming week. Now, many of you would say 60%, that's a pretty low number, but there are many reasons other than a prognosis as to why a clinician may not want to have a conversation in the upcoming week, related to patient preferences or other external factors. And so we regarded this very pragmatic number as good proof of concept that this could move forward into prospective testing. And then finally, when we ran the algorithm silently, prospectively, we showed that it had good performance in a real-time cohort, and it wasn't just an artifact of a retrospective validation across many different clinical areas. We then implemented the algorithm as part of a multi-pronged intervention that consisted of 3 parts. First, a weekly email to every clinician that documented their performance in actually performing serious illness conversations and compared them to their peers. As part of that email, there was a link to a list of high-risk patients identified by the algorithm, which clinicians could click on and review those patients for the following week. They had the option to opt out of an automatic text message reminder on that back-end high-risk list. If they chose not to opt out, they receive an automated text on the morning of clinic, a single text messages reminding them of each patient in that day's clinic that may be appropriate for a serious illness conversation. And that was the 3-pronged intervention. We showed that after deploying this intervention, the intervention resulted in a more than 3-fold increase in serious illness communication documentation among patients who were deemed high risk by the algorithm. As you can see on the bottom row, we increased conversations from 3.6 to 15.2%. Interestingly, we had a spillover effect as well among all patient encounters, even those who weren't flagged by the algorithms and for whom clinicians didn't receive text messages. We still saw an increase in serious illness communication documentation in the intervention groups, indicating that perhaps there is a spillover effect, a positive spillover effect towards implementing an algorithm to help shape clinician behavior. We learned several lessons from this that I think are generalizable to the deployment of predictive algorithms at the point of care. First, automated predictive analytics at the point of care can improve cancer care delivery and potentially reduce unwarranted utilization, particularly near the end of life. Rigorous solicitation and incorporation of clinician views makes for a better algorithm and a better intervention. This would not have been possible if we just chose to deploy an algorithm straight from the bat, rather than taking the time to get clinician viewpoints towards how they would use it. Thirdly, prescriptive analytics that are actually tied to an intervention, are much more likely to improve care than predictive analytics that are just a percentage that sits in the ether. And as a corollary to that, the intervention that you tie an algorithm to is arguably more important than the algorithm itself. And lastly, we should treat analytics like we do drugs and diagnostics and subject these to rigorous prospective trials. I'd argue that this is particularly important in the time of coronavirus and in the time of some of these changes in practice that we're enduring now. We need to be sure that the algorithm that we're using to shape care delivery, the algorithms that we're using, actually work and actually can positively improve patient care delivery. Thank you all for listening, and thank you to all my collaborators.